hosted by the Utah Department of Health, the Center for Medical Cannabis, based in Salt Lake City, Utah, and is recorded. So the public will have access to this. Public notice of this meeting was provided as required under Utah's open meeting laws and was posted on the Utah Public Notice website. In compliance with Utah's open meetings law, this meeting again is being recorded, and a recording of this meeting will be posted to the Utah Public Notice website no later than 3 business days following the date of this meeting. And written minutes will also be prepared of this meeting. And approved minutes will be posted to the Utah Public Notice website no later than 3 days after board approval as well. We'll do a member roll call, which I'll actually leave to you, Reshma, which you can do virtually because you see who's on the board. We don't need to do that out loud, but you can check the boxes. And then we have our Department of Health staff as well, who we've already introduced. And Dave McKnight is with us. I saw that. And Dave, it's always good to see you, to have your legal counsel behind us.
Thank you.
I don't know if there are any other special guests. If there are, or if anybody I have not seen other than Dr. Puckett, please announce yourselves. We welcome any visitors to our virtual meeting at this time. If you're logged in to the meeting with a phone number and not a name, please type your name in as a comment or state your name now so we can add your name to the meeting minutes. And if you do have any questions throughout or comments throughout this meeting, they are welcome. We want this to be as open and transparent as possible, but also orderly. So please use the functions at the bottom of your Zoom screen. There are 2 that I might bring to your attention. One is for chat, and you can address a chat question to Reshma Arrington, and she will screen them and then bring them up to our attention and to whoever they're directed throughout the discussion today. As well as there's a reactions section, and simply push the raise your hand if you've got a question or concern or comment that needs some form of urgent recognition, and we'll deal with that appropriately. So board motions and votes will be recorded in the minutes, and we'll now proceed with the agenda, which I'm going to pull up for myself, but essentially we usually start with board approval of minutes. So this I will handle as sort of a consent order of business. So well, first we'll just simply have a motion to accept and a second, and any discussion. If not, we'll just go through an assent process. So is there a motion to?
Hey, Perry, I just need to ask Reshma. I sent some edits last night. Were you able to incorporate those?
Did you send it? I actually haven't seen it. If you sent it to the whole group, we could just directly look at. No,
I just sent it to you.
Katie, anything of substance, or was it just simply?
Yeah, I felt it was. Instead of I described the conference that I went to, and I mentioned anxiety symptoms and new onset anxiety disorders in relation to use of cannabis. And it got kind of transcribed as psychosis, and that the effects are opposite. So I feel it was worthwhile.
Yeah, let's do this. And we've also had a bit of a discussion this morning. And Dave, I think you probably were listening in. I think you were on the line when we were having it. That I think that the minutes don't need to be so discrete and detailed. More, this is the subject we discussed, and these were the conclusions, rather than back and forth. So I would suggest maybe what we do is revise these minutes, since there are issues of concern. Katie and maybe Reshma, you and Rich can just sort of go through these and edit them to make them more broad-based, and then we'll just send them out by email and do a consent approval by email. All right, and then those can get posted. Is there any discussion around that point? Okay, so we'll move on then to the next order of business, which is quick review and approval of the autism spectrum disorder document. This has been reviewed by one and all, including Dr. Builder, who provided such a detailed review of the literature and summaries, as well as Dr. Ed Red, who initiated this process with a presentation to us. So it's we've had a very detailed discussion, review, evaluation, and presentation of evidence, literature, and conclusions and recommendations in the document from the board. And now all that's remaining really to do is to approve it so that it can be added to our online documents. Is there any discussion around the ASD document?
Harry, in the second paragraph at the very beginning, it still says for chronic pain. Shouldn't that be for autism?
Oh, was there a typo there?
Yeah.
Good pickup, Mike. Thank you. Okay. Given that typographical error, which will be changed and edited, any other discussion points? And thank you for your detailed review. It's amazing when you read these things, you sort of fill in the blanks according to what your mind wants to see, right? And takes a seasoned psychiatrist to be able to I haven't had my 10,000 hours of therapy to be able to do that yet.
So I just have a comment. So epilepsy is a comorbid condition of autism, and it's listed as such, but CBD is known to be good for some children with epilepsy. So, but that's not, it kind of just says it's not, there's no evidence that supports the treatment of the comorbid problems that I see. So I just don't know if we wanted to put a little.
Yeah, my interpretation of that, Karen, is that it's really quite literal, meaning that the only studies of epilepsy, certainly in children, that exist are around those particular genetic, disorders for which CBD has actually gone through formal studies and approved, which has, very well, whereas it really has not, according to Dr. Builder, in kids with autism who have secondary epilepsy. So if we just take it as literal, I think that it is what it is. It says what it says.
I just worry a little bit because kids with Dravet syndrome and Lennox-Gastaut often fall on the autism spectrum, and same with tuberous sclerosis. And so that's where it gets a little muddled. It's muddled.
Yeah.
But if you're going to include epilepsy as a comorbid condition, I mean, I don't know if we just want to put a parenthetical phrase in there, something along the line. However, if children have been diagnosed with Dravet syndrome, Lennox-Gastaut, or tuberous sclerosis, then Epidiolex might be an appropriate course.
Right.
And there is a separate document that's dedicated to epilepsy that may address some of those, correct, Reshma?
Yeah, however, the HIV, AIDS, and the cancer documents do talk about other conditions within their document. So if we did want to also mention how Dr. Wilcox says to add a special note on epilepsy to the ASD document, I think it would stay consistent with our other documents.
Right.
Sorry for the last minute.
No, that's a very thoughtful comment. The other thing that comes to mind there too is that in fact there are no pure CBD products that exist within the pharmacopoeia under the Utah program.
Right. That's true.
So we're really just referring back to the only FDA approved product, period, and other than the synthetic THC products that have other indications. So.
That's true. So this is guidance on medical cannabis. So then I guess that's a good point. Yeah. And so
it's
you wouldn't get it at a dispensary. You would get it actually at the pharmacy.
So that was a venal, not a venal sin of, or cardinal sin of omission, a lesser, a misdemeanor sin of omission. Maybe. All right. So do we have a sense of agreement, Reshma, I mean, and Rich, about, is there a footnote that's indicated there then, or should we just leave it as be? What does the board think?
I think just to clarify it, I think, Dr. Wilcox's recommendation, I think is a good one. I think we should just put a footnote in stating that we ought to go ahead and just mention that. I think it'd be worth mentioning what you brought up.
Instead of confounding everything, how about this as a middle, sort of a Solomon's a middle ground is simply where it says epilepsy, just simply have a footnote that say see epilepsy section.
Yeah, that's a good idea.
under
There you go.
guidance.
There you go. Perfect.
And we don't have to confuse things.
Yeah.
Okay.
And because you're right, I mean, it's not something they would go to a dispensary for, right? Something they would go to the pharmacy for. But yeah, I think that would work.
Okay. So with that edit in mind, do I have a motion to approve the document as part of our guidance?
This is Brian Zender, so moved.
Thanks, Brian. Is there a second?
I second.
Thanks, Katie. All in favor, just sort of acknowledge with a nod of your head. Yes.
Aye.
And if there's any, and most importantly, if there's any dissent or any abstaining, please acknowledge for the record. Okay, it is passed. Thanks. That was a very good process, and we will continue to proceed along those kinds of grounds. And with that, I'm very excited to introduce our guest for today, Dr. Megan Puckett. And I'm going to actually turn things over to Reshma to go through a little more formal introduction, since she went through the harrowing of the fields to find some expertise in this domain. And Alzheimer's disease is listed as a qualifying or approved condition under the current program. And so as part of our process to dig deep into these areas to determine what basis there might be, both in terms of potential benefit as well as weight against potential harms, this will be a very important addition. And this obviously doesn't pertain just to Alzheimer's disease, because oftentimes Alzheimer's dementia and other dementias are not so easily and readily differentiated except post-mortem, which is not what we do in medicine. So more broadly, we're going to be talking about dementing illness, and especially in the older population. So Reshma, if you would please do the courtesy of introducing Dr. Puckett. We'll hear her presentation and then have a discussion thereafter.
Yeah, Dr. Puckett's name came to me from some colleagues here at the Department of Health from Healthy Aging. She was highly recommended. She's a current professor of internal medicine up at the University of Utah. And from my knowledge, I know that she has a lot of research experience with using cannabis as a medical treatment. And I'm sure she'll go into that more. Before I hand it over to her, I just want to quickly mention that we have another guest here worth mentioning. Dr. Misty Smith is from the College of Pharmacy at the University of Utah. And she is actually, right now she's our guest, but we're hoping in July she will be confirmed as one of the new CPB board seats. I don't know if there's time, but maybe we could do a little introduction later on for her, or we can hold off for next month if there's not enough time. I just wanted to say that out loud. let's move on to Dr. Puckett's presentation, and I'll just let Dr. Puckett do a better job at introducing herself.
And is Dr. Puckett able to share her screen, Reshma?
Yeah, I will do that. Let me
Great.
get that. Okay, let me know if it's not projecting, otherwise I'll assume it is. Okay, so yeah, my name is Dr. Puckett. Megan is fine. I am an assistant professor at the University of Utah in the Division of Geriatrics, Department of Internal Medicine. And yeah, I'll be talking to you about the role of cannabis in the management of dementia-related neuropsychiatric symptoms today. A little background about myself, I guess. I did my medical training at University of Nebraska, where I'm from. And then I came out here to do my internal medicine training at the University of Utah, and then did a geriatric fellowship here. And then I just couldn't leave, and I stayed on as faculty. So here I am. So let's get started. So no financial disclosures or conflicts of interest to report. I'll talk a little bit about kind of the outline of how things are going to go today. So first, I'm going to talk a little bit about my practice. And I think that kind of helps see the lens, kind of helps you view the lens through which I look at, dementia related symptoms and how I approach things. And then we'll talk about some background in dementia and some of the neuropsychiatric symptoms associated with that. And then we'll go into some of the standard pharmacologic treatments, brief overview, and then get into kind of the meat of things, cannabis use for symptom management. The evidence for use, of which I will give you a preview, there is not much. Some of the adverse effects we watch for, and some of the geriatric specific considerations. So a little bit about my practice. I work at the Madsen Geriatrics Clinic at the University of Utah. It's a patient-centered medical home. We have all geriatricians. We have pharmacists, social workers, care managers, we have this big group, this big team that cares for our geriatric patients. I am the QMP for our clinic. So we decided to kind of set things up so that there would be one of us that was the QMP, the prescriber for our clinic. And I only take referrals from our own geriatric provider group. So there's a little bit of a almost like a vetting process to some degree before the patient even gets to me. And so this is a service we provide to our Madsen Geriatrics patients. And then I work with the PCP and the patient to kind of co-manage the issue for which we're prescribing this for. And so it's been a good system so far. And I think it's really helpful to have the PCP in my, we work very closely together, and I think it helps us, make sure we're doing the right thing for the patient. So it's a little background about my practice. So getting into some information on dementia. So this is probably a review for most of you, but I wasn't sure exactly everybody's background. So I wanted to spend a little time talking about the background of dementia and the neuropsych symptoms that go along with it. So dementia is truly a syndrome. It's an umbrella term for the syndrome of cognitive dysfunction that's progressive and affecting patients' ability to function in daily life. So there are a lot of causes of dementia, and Alzheimer's is the most common. But I think that to some degree, that is because we don't know, it's difficult to differentiate. And, with Alzheimer's being the most common, that's kind of our default sometimes. So there's Alzheimer's, there's Lewy body dementia, vascular dementia, frontotemporal, advanced Parkinson's with dementia, and then there's mixed dementia. So there's people can have both. People can have Alzheimer's disease and vascular dementia, and it gets really difficult to kind of differentiate that. And we have some, ways to try to do that with, PET scans and so on. But by and large, we're kind of just going by our clinical gestalt. So some of the neuropsych symptoms that can go along with dementia. So on the order of probably almost 90% of patients that have dementia will have some sort of neuropsych symptom at some point during their disease course. And what we consider neuropsychiatric symptoms include sleep disturbance. So oftentimes patients will get their days and nights mixed up, and they will kind of tend to sleep during the day and be awake a lot at night, which is very difficult for caregivers. Anxiety can be a big issue, and oftentimes that it's difficult for patients with dementia to express that they're experiencing anxiety or depression. And so oftentimes that anxiety can display itself in different ways. So it can be kind of this general agitation, irritability, restlessness. And then in terms of depression, oftentimes presents in apathy. So patients just kind of not being interested in doing their activities that they used to do, or poor appetite. That's a really big one for people with dementia. When patients get further along in their dementia course, they often lose their appetite, and they don't trigger themselves to eat and drink anymore. And so that's certainly a big issue for patients. And then there's psychosis. So hallucinations, delusions, paranoia. And this can happen in advanced Alzheimer's disease, but also in other types of dementia as well. So Lewy body disease and frontotemporal dementias are the other two big ones where the psychosis is predominant. And then many people have heard of the term sundowning, where some of these symptoms tend to get worse in the evening. And all of these symptoms tend to become more common with a more advanced dementia. So in terms of how do I approach these patients? So I try to think every time I do something for a patient, every time I start a new medicine, including cannabis, I try to think about what our goals are. What are we trying to achieve? So with dementia, some of the most common ones are delaying disease progression. So we can't change, we aren't able to change, mortality rate or lifespan, but we can, with some medications, prescription meds, we can kind of delay the progression of the disease. And so that's sometimes a goal for patients. A big one is improving quality of life. So these neuropsychiatric symptoms are very distressing for caregivers, but they're also distressing for the patient. If you just imagine, if you're just sitting in your recliner and you see a bunch of little kids running around in your house and you don't recognize them, that's very distressing. And so this is really a big quality of life issue for patients. And then we want to reduce caregiver burden and stress. These neuropsych symptoms are some of the biggest reasons that patients get institutionalized early. And we want to help kind of maintain patients' independence and function, and then delay institutionalization. So typical management for these neuropsych symptoms. So first, we always want to make sure we're doing some non-pharmacologic measures. So things like distraction, avoiding confrontation, avoiding correction, all of those things can go quite a long way. Cholinesterase inhibitors and NMDA receptor antagonists are the two approved medications for disease, not disease modification, but to kind of delay the progression of disease. And so these are medications like donepezil or memantine. For the kind of neuropsych specific symptoms, SSRIs and SNRIs are kind of our first line treatment. They can help with some of that anxiety and depression that patients are often unable to voice and unable to articulate. And then we use antipsychotics, primarily reserved for patients that are truly having psychosis, so delusions, hallucinations, etc. Sometimes we use anti-epileptic agents like Depakote for mood stabilization, and very rarely we will use benzodiazepines. So what about cannabis? Starting, I think around the time that the medical cannabis was approved here in Utah, I got a flood of patients asking me about, you know, using it for pain, for, you know, their anxiety, for their sleep, for, you know, just about anything. And then I started to notice that there were some family members, some caregivers that were, you know, really wondering about using it for some of the neuropsych symptoms for their family member who was having a really hard time controlling those symptoms with typical pharmacologic treatments. And the families have been they're desperate. So if they are, you know, many of them that are coming to me, they've tried just about everything and nothing's really working. Things are still really not going well. And so that's when our practice decided to pursue this and have me get qualified to prescribe. And it's been really interesting to kind of see how things go with older adults, because I think that's just in general, older adults are not studied often. So many studies, including studies on statins and antihypertensives and all of these things, they exclude older adults, people 75 and older. And so just in general, we don't have a lot of data on older adults, and especially not in the area of medical cannabis. So we're going to talk about some of the limited evidence today. So this is a little bit, I'm not going to get into too many, you know, details on some of the specific physiology, but there have been quite a few kind of in vitro studies that have looked at the connection between the endocannabinoid system and Alzheimer's disease brains. And so they have done some postmortem analyses of these Alzheimer's disease brains. And they have found that there is some altered expression of the CB1 and CB2 receptors in these brains. So the CB2 receptors, there's one study that identified that in patients with Alzheimer's disease, the CB2 receptors were selectively overexpressed in the plaque-associated cells in the Alzheimer's disease brains. And so just as a review, Alzheimer's disease, the true pathology is deposition of amyloid plaques and tangles in the brain. And so they kind of posited that cannabidiol could be neuroprotective against plaque toxicity in vitro. And they also found that the CB1 receptor expression was actually decreased in Alzheimer's disease brains. And they found that there's a correlation between the CB1 receptor expression and the degree of hypophagia, and so poor oral intake and poor appetite. So they found a correlation there. We also know that in Alzheimer's disease, one of the big contributors to the altered cognition is the decrease in total cerebral acetylcholine levels. And there have been a couple of studies showing that THC may competitively bind and inhibit acetylcholinesterase. So that's the enzyme that breaks down the acetylcholine. So theoretically, if we are inhibiting the acetylcholinesterase, that will increase the total cerebral acetylcholine levels. And that is actually how medications like donepezil work, is they inhibit that acetylcholinesterase enzyme. So this is a very brief overview of some of the posited connections between the endocannabinoid system and Alzheimer's disease brains. The problem is that how does this translate into patient care and clinical outcomes? That is what we don't know. And so I'll talk a little bit about that piece. So neuropsychiatric symptoms, long story short, there's low quality evidence supporting medical cannabis use for neuropsychiatric symptoms of dementia. There is some evidence, but it's all pretty poor quality. And I'll get into some of the details on that here in a bit and why that may be. So one of the best reviews I found was a Canadian review. They cited 12 primary studies and reviewed them. So there were 4 studies that showed statistically significant improvement in neuropsychiatric symptoms and 8 studies that did not. I'll get into a couple of those here. So there was a prospective cohort study that did show significant improvement in a few of the neuropsych symptoms. So agitation, disinhibition, irritability, abnormal motor movements, and then the nighttime behavioral issues. They also showed improvement in caregiver burden scores. In this study, it was 28 days duration, and they used doses up to a max of 7.5 milligrams of THC twice daily. But in some patients, lower doses were used. There's also another interesting case series that showed significant improvement in the nighttime behaviors and nighttime agitation over 14 days, and only using 2.5 milligrams of THC at night. And then there was another randomized controlled trial that showed an average increase in weight of 7 pounds over 84 days, or 3% BMI increase. And that was using 2.5 milligrams of THC BID. So these were kind of some of the best well done studies that I found. There are others, but many of them are very small or fairly poorly done. So I feel like in this realm, there are a lot of limitations to the study. So first of all, there's very few studies in general in this population and for this kind of purpose. And the studies that are out there are quite small, N of 30. And there's many kind of conflicting results and conclusions. So for every one study that has positive results, there's another study that says that there's no improvement. And so it's kind of hard to get a good sense, objectively with data, how helpful is this? And I think one of the other big limitations is that there are so many variables that are difficult to control for. So, with older adults that have dementia, we have to make sure that there's a caregiver, to study. We have to make sure that there's a caregiver who's, able to administer the medication at a certain, as directed. Patients with dementia usually need some assistance with that. And so I think, that's a big limitation. And then, there's obviously some stigma around use. And so I think it's often sometimes difficult to recruit patients, especially here in Utah. I've noticed that it's people are pretty hesitant and pretty wary. So that's certainly been that can certainly be an issue. And a lot of the studies in terms of using a certain dose, they will kind of give them a range or et cetera. And so there's a lot of variables. And then a lot of the studies are actually that are out there are using synthetic THCs rather than true just medical cannabis. And so that's another limitation. So we're kind of also extrapolating data from that. So there's also been a lot of studies in terms of adverse effects for older adults and patients with dementia. And overall, in most of the studies, the adverse effects were pretty mild. There were a few instances where there was actually worsening of neuropsych symptoms and worsening of psychosis. There was, I think sedation was the predominant side effect that was noted in most of these, and then gait instability and balance issues. And when I discuss risks and benefits with patients, when I see them in clinic, we certainly go through all of these things. And when we, talk about sedation and possible worsening symptoms, et cetera, that can be kind of scary sounding, but it's actually overall can be quite minimal in comparison to some of the prescription medicines. So antipsychotics have a black box warning for death in patients with or in patients with dementia. And this is primarily related to oversedation. And so we really try to minimize use if possible. SSRIs are generally pretty benign, but not completely. I have a lot of patients that can't take them because they develop significant hyponatremia on them. And so there can be some sedation or anxiety related to that, GI side effects, even worsening neuropsych symptoms. Benzos are probably the worst, can contribute to a lot of cognitive impairment, like worsening cognitive impairment, delirium, and fall risk. So there's a few geriatric specific considerations that I always think about whenever I am prescribing for a patient. So first of all, sensitivity to medications. So there's no data that says that older adults are more sensitive or have more side effects to cannabis than younger patients. There's no data to suggest that. However, in my experience, just prescribing other psychotropic medications, older adults tend to be a little bit more sensitive. And so whenever I'm prescribing medical cannabis, I treat it like a medication. And I start low and I go slow and monitor. And so we really have to be careful about side effect monitoring in these patients because people with dementia are not always very able to give you a good history. If you say, are you having any side effects? They're probably going to say no, whether that's true or not. And so getting the caregiver involved and doing a gait assessment. So, assessing whether they're having any gait instability or worsening sedation, and being specific when you ask the caregivers about these things. And then safety and supervision is a big one that we often kind of overlook, but, we have to make sure that things are safe. So putting medications, so any psychotropic medicine, if I'm prescribing like any pain meds or benzos to, a patient with dementia, I always want their meds to be in a lockbox so they aren't able to access them on their own without the caregiver being present. And that goes for cannabis as well. And then the last piece is what matters most. So for some people, you know, maybe the mobility or the, you know, sedation, maybe that's not so big of an issue. Maybe controlling these very distressing neuropsych symptoms is more important to them. And I think having that discussion is really important. So how do I approach these patients? So I get the referral from my colleague, and then I have them come in for a consultation visit, and I do a brief geriatric assessment. So we talk about goals of therapy and their goals of care, like I just mentioned. And then we do some symptom assessment. I look at all of their medications and look for any other psychotropic medicines that could also be causing sedation or gait instability. And then I do a gait assessment. So I watch them walk up and down the hallway, both before I prescribe and at follow-up visits. And I think it's something that we often don't do in clinic because the patient's already seated when we come in, we talk to them, we examine them, and then we leave, and we don't even watch them walk often. So I try to make that a big priority in these patients. Then I always have a risk benefit discussion, and I'm very open about the lack of evidence. And then in terms of the prescription, I always let the PMP determine the prescription. But because I'm kind of protective of my patients, I can't help but give some of my own guidance. So again, I advise them to start low and go slow. So I'll usually advise that they start with 1 to 2.5 milligrams at night or in the evening, and then have them monitor for, 4 or 7 days and see how things go. And then, if things are going okay, we can up titrate as needed. And I try to help them. I try to help provide some guidance in terms of, what is, we're looking at their goals of therapy and their goals of care. Well, what's the bothersome symptom we're trying to address? Is if it's sleep and sleep disturbance and, getting up and down during the night, maybe we just need a little bit at night to help calm things down. And, we kind of play it by ear. And then I see them for follow-ups and make sure we're addressing any adverse effects, screening for those, and, talk about dosing guidance and how we can make things a little bit better. And so that's kind of how I approach things. And then I will say, although there is very little good data on this area, in my somewhat limited experience, these patients are seeing benefit. And I think the primary areas that I've noticed kind of anecdotally improvement for the patient and their caregivers is in a lot of the nighttime symptoms and the poor appetite, cachexia, and this kind of anxiety, agitation. Just kind of anecdotally, that's what I've seen. And I am pretty forthcoming with patients about that. When I see them, I tell them, there's really not a lot of data out there, but, from my experience, kind of anecdotally, this is what we've seen, and this is what's been helpful for other patients. And I think that is helpful for them. So I'll open it up for questions if anybody would like to.
Yeah, thank you, Dr. Puckett, so much for that actually very concise and a thorough review. It looks like Dr. Woolsey is going to start us off with a question or comment.
Okay.
Yeah, thank you. That was a great overview and description of what you're doing. Are the patients that you're seeing antipsychotic naive? Are you trying to see them before those are used, or are they weaned off of them before you start? And any comment on sort of drug-drug interactions or things you're comfortable doing or not in those patients? Thank you.
Yeah, great question. So, truthfully, it depends a little bit on the primary provider that is sending me the referrals. So the by and large, what I've been seeing lately is patients that have tried SSRIs, some of the more benign medications, and things are kind of escalating to the point of, we may have to start an antipsychotic or a benzodiazepine or mood stabilizer, something more heavy duty. And the provider is hoping to avoid that. And we have a geriatric psychiatrist in our clinic, Deborah Morgan, who she is probably one of my bigger sources of referrals. And so, we've only been doing this for, 6 months or so, but we are kind of trying to get a system down and trying to kind of figure out kind of at what point is it most helpful to think about starting this. And I forgot the second part of your question. I apologize.
Yeah, just that's great. It sounds like you might add it to an antipsychotic, but you also may use it before an antipsychotic. And then I guess just have you observed that she weans them off their antipsychotic before she tries it, for example, or I'm just curious. And then the second thing, what forms do you recommend for this population?
Kind of what we'll usually do is, start the medical cannabis and then see how things go for a month or so. And if things are going well, then try to wean down on the antipsychotic or the benzo or what have you. And then in terms of forms, so most of my patients end up, we typically, I kind of encourage them to go with kind of the gummy form, or because they can kind of cut it down and really kind of to some degree play around with it and experiment with that a little bit. And I feel like I always see them coming in 10 milligram gummies, which is way more than most of my patients initially will need. And so I encourage them to kind of cut that down into like quarters to start with. And then I'll have them start with that at night. And that way, if there's any super significant sedation or side effects, it's in the evening, which is a little bit better tolerated.
Thank you. That's great. Appreciate it.
Megan, this is Perry. It seems to me there are two sort of big populations that sort of arbitrarily fall into one of two buckets. There's individuals who are in some kind of facility, long-term care, or progressive from assisted living, then progressing on to more intensive care. And then of course, memory units. And in those latter settings, they're very behavioral modification and management intense, where they really try and use direct care methodologies rather than drug therapies to modify sleep, agitation, severe anxiety, and then only, titrate drugs very cautiously, and are pretty successful. I mean, in the higher quality facilities but of course, those are limited to people who have access, and they're very costly. And then there's sort of your generic nursing home environment, which can be kind of mayhem and very difficult, which then rely more heavily on pharmacotherapy that may not be in the patient's best interest, but it's in the caregiver's interest to prevent injury or abuse or other things that may occur. And then there's the home environment. And I'm wondering sort of where your experiences in at least in the cannabis as medicine world sort of fall into those three buckets in terms of utilization or success or your observations. Oh my God.
Yeah, great question. So, yeah, you're absolutely spot on. In the nursing home, true nursing home setting, usually we're talking pretty advanced dementia and often pretty significant neuropsych symptoms. And it's interesting, and I'm actually, so actually really quick to answer your question. So predominantly the majority of the patients I see are at home with a caregiver. And then there's a few that are in assisted living. And things get a little tricky when we get into the nursing home setting because of who is managing the patient. So an outside primary provider can manage patients in assisted living, independent living, but when it comes to true nursing home care, they're really predominantly under the care of the house physician at the nursing home. And so at that point, so I certainly have more impact and control over, medication management for patients in assisted living, independent or home environment. But I am actually interested, I think so in the nursing home setting, there's a lot of quality metrics that are measured. And one of them is antipsychotic use and psychotropic use. And so they are always looking to minimize their antipsychotic use. I guess a little bit for, hopefully, mostly for the patient, but I think truthfully, mostly for their metrics, if I'm being honest. And so, we always kind of talk about, how do we implement change, and it's, getting the stakeholders, figuring out what the stakeholders need and what their priorities are. And I think oftentimes for some of these facilities, that is one of their big, priorities, is keeping good metrics, looking good on paper. And I actually think it would be really interesting to see how this might work in a true nursing home setting, memory care nursing home setting. And I have a lot of, ideas on projects that I want to work on. And I think that's one very interesting piece of that puzzle is, the nursing home setting and figuring out, how well does this work in very advanced dementia, and, minimizing antipsychotic use and things like that. So I think that would be a really interesting area of study.
So this is Ed Red. I got a question.
Go ahead, Ed.
So in your presentation, you mentioned mostly, milligrams of THC or tetrahydrocannabinol. In the products that you're using in these patients, is there any cannabidiol component to it, or do you keep track of that, or worry about that, or how does that work?
So yeah, so most of the patients that I have end up receiving a 1-to-1 ratio of the CBD to THC, and I guess I don't really worry too much about that. I think that's one piece that's kind of determined by the pharmacist, and I've kind of just allowed that to be the case, and kind of been focusing more on, helping the patient figure out how to titrate on their own. But I don't see any significant negative in using that form. I think it's in my, experience has been very helpful for patients. So.
Do you have any experience using just straight THC in the same milligrams without the CBD? Or is it always one? I think 1-to-1. I mean, it makes a lot of sense to me to use some cannabidiol to reduce the risks of psychosis and other adverse effects from THC. But I just wondered, I'm always curious what people are using when, because oftentimes we look at the THC content, but we fail to realize that sometimes the CBD content has a significant effect on how the THC is metabolized and how it affects people's brains and all that sort of thing. So I just was curious about that.
Absolutely. And I really, so off the top of my head, I don't think any of my patients are getting pure THC. I think they're all getting a 1-to-1 ratio.
Great. Thanks a lot.
Mm-hmm. Anything else?
Dr. Perry, you're muted.
Sorry, thank you. Can we unshare Megan's screen for a second so I can share my screen and pull something up for everybody to look at?
While
Okay.
you bring that up, I was just gonna ask Megan about what has been the report from patients on the availability of one-to-one products in Utah? Have you heard back from them on that?
Yeah, so most of my patients haven't had any difficulty or issues that I have heard about. So
Okay. Good to hear.
I'm trying to see now if, are you all seeing my screen?
Yes.
Are you seeing the guidance document?
No.
No,
You're
I'm not
not.
seeing your screen.
I'm not seeing your screen, Perry.
Uh,
There you go.
It's coming.
Looks like it's coming.
Is that it?
Yeah,
Are you seeing it now?
yeah.
Yes.
So this is the guidance document. I don't know if you've seen this, Megan. The rest of the board has. This was this is on the Department of Health and Center for Medical Cannabinoid Product Board website, and you can see it's got all sorts of disclaimers and formalities above it. But the meat of it is this little section right here, which is very short. It's probably one of the most brief of all the guidance documents, largely for the reasons you stated, which is there's just not a lot of study. But it seems to me that from your presentation, you have sort of reiterated what our literature review, maybe about a year ago, pulled up on this. And there may be some other little tweaks we can do, but I didn't see that there was a room for a lot of editing or changing on this document. And I'm just wondering if you look through this of the time we have together, do you see anything here that would demand a change or an updating? I think the Health Canada document that it refers to in 2018, I think summarized largely most of the clinical trials or the controlled trials that you had summarized. They did come out of Canada. I'm aware that there are some studies that are either being ongoing or being considered largely in Israel with this notion of microdosing, very, very small doses of THC combined with either by itself or combined with higher doses of CBD. But those data have not been published, and it's just aspirational right now.
Yeah, so I looked at I didn't, to be honest, I didn't look at this right before my presentation, but when I first started prescribing, I did review this, and it was very interesting how short it was, especially in comparison to some of the others. And, you know, I don't see anything that I feel like needs to be changed. I think one of my concerns is that, and I don't know how you guys, I'd be interested to hear your view on this, but, you know, Alzheimer's disease is the qualifying diagnosis. But as you mentioned, Perry, it's really hard to sometimes differentiate that between other types of dementia. And so oftentimes we just say dementia, unclear underlying cause. And so when I'm, you know, kind of, to me, and I guess we don't know, there's not a lot of data saying, oh, it works better for this type of dementia or what have you. You know, we don't have any data to suggest that. But I'm kind of curious why it is outlined as just Alzheimer's disease rather than dementia in general. I'm guessing there's some background on that, but.
I'm going to refer this to Rich Elborn. This was sort of a political process. Rich, do you want to comment on that?
I repeat the question. What was that?
Oh, why is it just Alzheimer's disease as the qualifying diagnosis rather than dementia?
That's a good question that for, I think, policymakers, as they evaluated, I think, other states, that they got things that they saw other states were doing. Also, it was a compromise. So as they were negotiating what would be in the, what was the HB 3001 that came after Proposition 2, they were negotiating what should be in HB 3001 that the legislature passed. And that, as you know, made significant amendments to Prop 2. So I think I don't think there was much debate about that specific issue. So that's something that would be maybe better addressed by a policymaker than myself.
This is Ed Red. I was there for that discussion, and we really did not get into, we didn't dig in deep into the whole concept of, oh, by the way, there are other forms of dementia besides Alzheimer's disease. And quite honestly, Alzheimer's disease is sometimes a postmortem diagnosis based on brain biopsies or things like that. So I think it's more probably the intention, I think, was for dementia in older adults and not necessarily specifically Alzheimer's disease. That was my recollection of what we were talking about back then. And so it's I guess what you call an oversight, because we didn't have dementia experts in the room putting in their, giving us their input on this. And so I think if somebody wanted to change that in the next session of the legislature, would be a small change in the code, because I think the intention was for management of people with various types of dementia, not just Alzheimer's disease. That's my recollection of what we were talking about back then.
Thanks, Ed. And a couple of thoughts then. First of all, the process by which we would do this would be a recommendation that would come through the board at the annual updating of the Health and Human Services Subcommittee, which will occur next fall. And we can certainly do that and speak more generically about dementia as a syndrome with different diagnostic categories, but overlapping manifestations. The underlying pathophysiology may be different, but again, as we said, we can't necessarily differentiate that usually. So that's something that we can do and probably should do based upon what Ed's comments were. And that's a very good pickup. The other thing I think that I would like us to discuss for a minute with your input, Megan, if you'd be willing, is that, when we went through the, and you just caught a bit of the process with the autism spectrum disorder, we'd really divided that up into two sort of things. One is primary disease, underlying pathophysiology, and the second is secondary behavioral manifestations of the syndrome, regardless of the underlying pathophysiology. And I wonder, and with the board's thinking on of doing a bit of a modification of the let's call it dementia rather than Alzheimer's for the moment, is that we can maybe for the sake of educating qualified medical providers and then the limited providers that create all those individuals who may recommend cannabis for medical use, as an educational document, we could specify more fully the different types of pathophysiologies. But then the conclusion I think that we would come to from the evidence review is there is simply no evidence whatsoever excuse me, at the current time that cannabis or cannabinoids, even though the endocannabinoid system may be involved and there's some theoretical bases, there's no evidence that the primary disease processes are modified or altered necessarily by the use of cannabis products. On the other hand, and there are concerns about risks that are unknown as of yet. So caution is due. On the other hand, there are these other manifestations, and especially the neuropsychiatric ones that we can elaborate, that you spoke of, and elucidate, and then state that the reviews of literature suggest that some patients, anecdotally, and in some randomized controlled trials, there's some weak evidence that may support very low dose THC coupled perhaps with CBD. So in the products that that patients have access to in the Utah program, it's sort of low dose THC, higher dose CBD, equivalent doses, or the reverse. So these so-called chemokines that exist, and that's still sort of being sorted out. But at least we can give some guidance similar to what we have with other conditions, and in those specify that again that it's low quality evidence, and close monitoring and supervision and evaluation with very slow upward titration would be the process. So I think we can flesh out and elaborate this very similar to the way we did the last the autism spectrum disorder, given the paucity of evidence, but also given that there may be demand largely because of caregiver stress, in the same way that we witness with caregivers for autism spectrum disorder. The problem lies in many ways more with the caregiver and distress than with the patient. So wondering, I know that's a mouthful and the board is used to me, my mouthfuls. But with that, any thoughts or discussion about this? And if we want to go in that direction, then the question is, who wants to volunteer to do this? Megan, would you be interested in taking your presentation and elaborating it in a little more of a written form, and then we will help edit and work with you to do that. If that's something you don't want to do, no pressure. But I'm doing the 5,000 years of cultural guilt is the gift that keeps on giving sort of approach to be a bit of a coercion here.
Absolutely. I'm happy to help with that.
So what does the rest of the board think? Is that is that something you think would be useful to the providers and the public to flesh this out a bit more in that sort of a way? We have a very shy group here, right?
I think it would be really helpful to again, this current document doesn't say anything about the actual progression of the disease process. I think it'd be important to point out that we are kind of using this intervention as to try and help people that have really severe challenges, and their caregivers that have severe challenges. I think that's really important to sort those two issues out. We're not advocating using this to change the trajectory of the disease process as much as we are trying to help manage the comorbid symptoms that these people experience and their caregivers experience. I think it's really important to point that out, and I think I'm totally in favor of modifying the document.
I do think, it's a helpful distinction to make because, I think when people see that is a qualifying diagnosis, they might, think that it could be a true treatment for Alzheimer's disease. And we know that it's not. Really is most helpful for the caregiver stress and the kind of neuropsych symptoms that come along with the disease rather than the disease itself. I do think that's an important distinction to make.
I think the other thing that might be really important is to make sure that people understand that, as this is, probably during the next legislative session, if our recommendations are taken, they'll probably change it to dementia rather than Alzheimer's disease. But I think it's important to point out that we have, the limited data we have is probably mostly in patients with Alzheimer's disease. We have no clinical data to help us know exactly what's going to happen when we use it in other things like that are different than Alzheimer's disease, and maybe present differently and might respond differently to cannabis interventions. I think that's important too.
Or we're presumptively diagnosed with Alzheimer's for entry into these studies, so that's a little ambiguous too. But I certainly think if we do revise this document and consider the larger category of dementia, this will be fully presented to Health and Human Services Committee. And I think that's really our role. In fact, what you're witnessing, Dr. Puckett, is a work in progress as this board develops and refines through this iterative process of reviewing this sort of bucket load of qualifying conditions we were handed, and now trying to retroactively work through them and determine what is the evidence, and how do we sort of manage this and provide the most useful guidance to all who are interested in participating in this program. So you're now an active, you've been recruited as an active participant in this larger social experiment. And we thank you for that. And thank you for volunteering to do this. So I think as a process, if you would just sort of have at it, no pressure, over the next weeks to month or two, if you would work at it, stay in sort of in touch with Reshma and or myself. I'm at the university. In fact, I'm just up the block from you. Actually returning to seeing to clinic myself now once a week, which has been delightful. But we'll help work through this with you if you need help in any way. We don't want to overburden you, but we really appreciate the effort you put into this, and your DNA then will be all over this this process, and greatly appreciated.
Thank you.
Anybody else who wants to input and work with Megan, just get in touch with her. I'm sure she would appreciate whatever efforts you can help her with. Comment from somebody? I heard a voice.
This is David Sunwell. Can you hear me?
Dr. Sunwell, welcome.
Hi. As a QMP who's seeing a fair number of these patients, I welcome this. This is a good discussion. And it has come to my attention, this silly notion that this is curative. And I've had to dissuade patients that, no, if we're going to try this, it would only be for associated symptoms or things. It's certainly not a cure for Alzheimer's. And I also Ed, thanks for saying you'll fix this in the legislature, that they will, because clearly dementia is not always Alzheimer's. So this has been a helpful discussion. Thank you.
Another place we may want to proceed with this, Dr. Puckett, is that we're actively working at engaging one of the research groups. I don't know if you know Jerry Cochran or Adam Gordon, also at the University Department of Internal Medicine and Psychiatry, in the PARCA program, which is largely around addiction research. And so they have a strong interest in working with us, establishing and refining our database, for which we may have some support and funding through the legislature up and coming. And that's all sort of in process now. But one of the areas, as you said, that you're interested in researching, and we've been talking about cohort studies, and what kind of a cohort study would be most revealing. And certainly in this area, this would be a very discrete group of patients where we could evaluate over time, not just behaviors such as sleep, although using things like pedometers or kinetic monitors to look at activity during evening hours versus daytime hours as objective measures. Things like get up and go tests, things that can actually be objectively measured, but also cognitive testing and decline over time, use of words, memory for short-term memory of word testing, and face of the clock kind of things. The basic, really elementary neurocognitive testing, not the formal stuff, but just to determine whether, from a perception of objective measures, but also from caregiver perception, if there are any changes given use of cannabis products. So if this is something you're interested in, I think what we would do, Reshma and Rich, would maybe invite Megan to participate along with some of our discussions over time. And as Sarah, I think Sarah had to cut out of the call for a little bit. But if you're interested in being part of our little research cabal going forward on how we're going to develop database assessments for different conditions, but also and inputs and outcomes, but also potentially cohort studies, we'd love to have you join. And so if you and perhaps Rich or Reshma could just stay in contact about that, we'll sort of get you on board.
Sounds great.
Right.
So this has been a very productive relationship building. Thank you, Dr. Puckett, for joining on. Any comments from other board members or others on the call before we move to some a little more some basic housekeeping stuff? And Megan, please stay on or peel off if you need to, because we're just going to do a little
So-
housekeeping.
Just briefly, we just need to make sure we somewhere put in the notes to kind of a to-do list for our October presentation to the Health and Human Services Committee, making recommendations to change the state code. Because we've had this discussion, but I hope we remember to,
Oh yeah, we'll
talk to them in October about this, because I just, so Reshma, if you could just make a note of, or Rich, to put that on the list of to do for the next legislative session, because I just don't want to forget about it. That's it.
yeah, they're part of my hard drive
Yeah.
accessory brain. But, that'll be probably my last deed of the year. Alrighty.
Yeah. We'll make sure it happens.
So just to review for folks on a housekeeping basis, we are now, we had a very productive meeting with Senator Vickers, who has really working with us to think and consider about how to expand the research sort of arm of what this program is all about. And where funding may be available to do that. We're actively engaging the discussion about changing the and more appropriately matching the name of this board to the legislative mandate that we have, which is really to review and evaluate current evidence and research and especially IRB approved studies relevant to cannabinoid and cannabis use as medicine in these different categories of conditions. And so one of the names that that we've sort of come up with that seems more apropos, rather than, since we're really not dealing with products specifically, that's really in another domain, is as a cannabis medical review board. This notion of medical cannabis with medical being a descriptor, it's hard to say that in a objectively honest way that this product here that's exactly the same as this product here. The one is medical and one's recreational. It's really about intent of use. So cannabis as medicine or cannabis as a cannabis medical review seems to be more pertinent to what we're actually really doing. And so Rich, as the director of the program, is working through that process. So we're going to have a lot to discuss with the Health and Human Services Interim Committee next time we do get together in the fall. And that's just a formal policy process that Rich is working through. So there's a lot of dynamic moving pieces right now that's both expanding, but also focusing the work we're doing. Next month, Karen Wilcox, bless her heart, who we will miss sorely and dearly, but we know you'll be polite and say you'll miss us too, but I'm sure you'll find other things to do in your,
I will find other things.
You have a lot on your plate. Is going away, but not very far. And Karen's going to give us I think, or have one of her representatives gives us a little discussion about just sort of a pharmacological or applied pharmaceutical discussion next time about, is there a role for and what is the rectal route in terms of absorption and differences versus the oral route, if we're talking about bioavailability and perhaps biotransformation of cannabinoids and cannabis as cannabis product as well. So Karen, if that's still on deck for that, great, we appreciate that. And then on into the near future, either next month or July, we're hoping that Dr. Dan Odell, who is part of the Division of Pain Medicine and works as part of the supportive oncology group at Huntsman in the palliative care domain, there will be giving us a deep dive into cancer pain. We haven't had any takers to get into other cancer-related symptomatology, although he may cover that a bit, or the role of cannabinoids as disease-modifying agents in cancer, which is a fascinating and interesting field that's just beginning to open up, and obviously a lot of potential, but very little reproducible evidence as of yet. So we have an interesting few months ahead of us. One of the discussion points that came out in before everybody got online this morning was, as we move into the summer and then the early fall, where we anticipate the ability to actually congregate again indoors safely, perhaps in the fall. Question arises as we've become so adept at Zoom, and it's so efficient in terms of saving time in travel, the risks of travel for all these sorts of reasons, but also gasoline and air quality and all the things that happen when we start transporting ourselves around. One thing I would like to maybe bring to your minds is, and of course this would be the, at this point, Dr. Crookston and Dr. Wilcox will be replaced by others, that we may perhaps continue to meet on a Zoom basis on a monthly, but then either quarterly have in-person meetings, because things happen a little differently in person. The dynamics are a bit different, and a little different level of discussion and so forth. So something just to think about. We don't have to come to any conclusions, but that's sort of one of the things that Rich, myself, Reshma, and Sarah are thinking about from an organizing standpoint. And not to diminish the role, but still under, I guess, the rubric of housekeeping, we will be having 2 brand new board members as of July. One of them, who's been vetted, and we can see her smiling face, is Misty Smith, graciously accepting and for maybe an offer she couldn't refuse, Dr. Wilcox's invitation.
She could have refused me if she wanted to. Misty's going to be a great addition to your group. It'll be.
So Karen, would you want to go ahead and, since we have Misty joining us, to do a little bit of an introduction, just as this way, Dr. Crookston and can just get to know who's going to be, what he'll be missing out on.
Okay, I'm happy to do that, although Misty can certainly chime in when I forget things. So Misty is an associate professor in the School of Dentistry, and also has a joint appointment in the College of Pharmacy and our department, Pharmacology and Toxicology, and she is a co-investigator on our epilepsy therapy screening program. She is our Schedule I license holder here at the university, well, in our department and in our group, for helping bring in cannabinoids and other marijuana-like products so we can use them for testing in our screening program. So she has a really deep depth of knowledge of what it takes to actually do research with these compounds. And so that's going to be really a benefit, I think, for you guys. Also, her research program has been focusing on the role of cannabinoids in the treatment of epilepsy and neuropathic pain. So again, from a basic science perspective, she can lend a lot of really keen insights, I think, into mechanisms of action of these compounds and their use, certainly preclinically, but also in patients as well. She's written a comprehensive review paper recently with the folks from GW Pharma that kind of describes some of the preclinical work that was done on their compounds, and really is just a wealth of knowledge. She's given many invited presentations on cannabinoids to different departments of health, I think in Montana as well, and a couple of other places. So she is viewed as, at least in our department, an expert on cannabinoids. So I think she's going to be a great and way better replacement than me for me. So you guys will really enjoy having her on. She works really hard. So. Misty,
well, Karen, thank you. And Misty, that's a great introduction, and it'll be a joy having you. And in fact, Dr. Red, where did you go? You were just here. Did you just disappear?
There was just a chat from him. It says he's needed at the Bear River Health Department.
Oh, okay. Well, I was going to pick on Ed because one of the areas that he feels we really should review in the next sort of list of things we want to get to is epilepsy. This is an area of great interest, and so he was sort of looking and seeing what kind of networking he could do to find somebody in the sort of epilepsy and epileptology world do this. On the other hand, with Karen's introduction, Misty, you sound like you would be perhaps the perfect person. Now, I don't want to scare you away before you even join, but if we think of forward several months, because we have an agenda, as you see, with it that'll maybe get us through the late summer, early fall. If you would be interested, we would love to have you review the current guidance document that exists under the website, which just go to the Cannabinoid Product Board website, and there it is, and pull it up, and to sort of review it and look and see if we're in that you believe some meaningful updating, and sort of looking at some of the other areas we've reviewed, such as we talked about today, and sort of see the format we've used for these different conditions. And then perhaps as our visitor today did, give us a sort of a presentation on, to give everybody sort of a grounding in this, and then we could proceed from there. Was I complying with the Geneva Conventions in terms of coercion there, or did I?
I would be happy to do that. That would be
Yeah,
perfect.
great.
Yes.
This is the prerogative of the chairman too. Okay, well, great. Well, we have our work set out for us then, and again, welcome, Misty, and you just in the nick of time. It's kismet. It's very fortuitous.
Karen, for that very kind and generous introduction.
Wonderful. So we now have an opportunity, as we always do at the end of, as we come to the end of our meeting, for any thoughts, comments by any of the other folks on the call. Looking for hands, and I don't see anything at the moment. So with that,
I'd just like to give the chance to Mark Viner. He raised his hand earlier in the meeting. I don't know if he still has a question.
Oh, I'm sorry, Mark. I didn't see it. Forgive me.
No, that's okay. I'm just a first-time attendee. I'm based in Nevada. I'm a board-certified psychiatrist, and I have several patients that, I help with cannabis. And I just had it's really okay. The dementia issue, we use the term neurocognitive disorder, and there's so many different types now with so many different treatments. You have your Alzheimer, the vascular, the HIV, brain injury, ALS, Huntington's, and all the treatments are Parkinson's, for example. So I don't know if it might be beneficial to split up the dementia into those different disorders, because some of the cannabis research is getting better, like with Parkinson's and dystonia, and then, stuff like that. And vascular, you got to watch out with bleeding, with drug interactions like aspirin and NSAIDs with CBD. And so, they use the inflammatory model for Parkinson's. So a lot of the anti-inflammatory effects might be useful. So, and then with Huntington's, they have gene therapy now that'll fix that. So that's a very big word, dementia. And then the neuropsychiatric part, the psychiatrists tend to be more against cannabis, because they're just a little bit behind in the research. So, you know, we could talk about sometimes the other symptoms with the dementia, like for just one example, Parkinson's and dystonia. There's some good studies that show it might be beneficial. So that's a real big topic. It's going to be hard to just keep it as dementia and then just the psychiatric side effects. There's a lot more work coming out now with actually, you know, disease modifying. So even with Alzheimer, I know it doesn't cure anything like the other speaker said, but you know, with the tau protein that, you know, can affect the other tauopathies. So, and the only other thing I was going to say is on the ADHD, I mean, on the ASD, if you guys have a CBDV available at the pharmacies, because in about 12 weeks, the big study with the Defense Department and NYU using CBDV for seizures and autism, or just autism they're studying it for, is going to be coming out. So it might be useful to how often do you reevaluate your suggestions? Because there might be some new work coming out in a few weeks. It was a 3-4 year study that's about to close with CBDV for that. So anyway, I was just for autism. So, and there is a couple new articles that it can say it can decrease. There is some disease modifying data that was published. It was presented in a poster in Canada by the University of Louisville doctors that showed it decreases utterance frequency in autism, increases nonverbal IQ. Those are some of the, what you guys call the core symptoms of autism. So I don't know, how often do you update the guidelines? Once a year? Or would that be something you would look at again if some new data comes out this year on autism, or how's
Well,
that
Mark,
work?
you know, I'll just go Mark on Perry to you, and I'll be just be informal here. That's really helpful. And first of all, welcome as a first timer, and your first, I think you may be our first out of stater. So this is great. Yeah. And please join us whenever and however these thoughts are really very welcome. In terms of cannabivarin and other cannabinoids, yes, you're correct. There's a lot of research going on now looking at cannabinoids pharmaceutically and also rather than just pure as extracts, but just like with cannabidiol being extracted, but now it's also synthetic and available. This research is going to explode, and so it will require an ongoing evaluation. The products that exist in Utah are not pure, purified pharmaceutical grade extracts or synthetics. They are plant-based and whole plant-based either extracts. So they're very complicated. They're not simple. And so those other than CBD and THC are not measured. And those the CBD and THC is measured as a requirement. So this is just the very beginning of things. But in terms of a timely review, this, as you can see, is a sort of a volunteer group, and yet we're trying to be as rigorous as we can and as active as we can be in doing this. We will count on people like yourself to keep us aware of what's available in the literature and people with expertise as we do review these topics. And if a year from now, there's 2 or 3 new publications that are meaningful, we would like to update whichever category we're looking at. To that end as well, Rich Oborn and Sarah Woolsey, who are sort of the poobahs of the program through Public Health Department here, are looking at being able to bring in a either part-time or full-time PharmD into the administrative arm of our who are paid employees, if you will, to be able to commit full-time over the course of these next few months. We're not sure whether this will be a part-time, full-time job. This is a different discussion, but with the view of being able to be much more dynamic and active and proactive in reviewing these sorts of things and using expertise, especially in the pharmacological domain. And I think I would sort of summarize what you said and some thoughts I've been having, which is that the work of this group is largely about applied clinical pharmaceutics, with the applied being individuals with clinical experience and active patient engagement are part of this group. And so, as well as of course, all of the people recommending cannabis products are they're either MDs, DOs, PAs, or advanced practice nurses. But what we're working off of as a foundation is a knowledge base that's largely in pharmacology or in applied or clinical pharmaceutics. And so having Misty join us from the university as moving in as Karen moves out, we're going to be looking at in discussion with a similar role from Intermountain Healthcare, which is the other large healthcare delivery system in Utah. And with those two healthcare systems, it's about 80% of the population of patients being treated in the state. But actually, right now, a de minimis number of people recommending cannabis. So there's a bit of a disconnect there. So we're going to be looking at how these systems and processes become operant within our program. And so all of your comments are highly relevant. I'm really important and glad that you can join us and keep us on our toes. And with that, we're going to, it's now 10:42. So my goal is always to get out of this a little bit early, give people a chance to get back and plan for their next hour. And so if there are any other concluding comments, speak now or for at least a month, hold your peace. All right. Again, thanks all for joining us. Stay well and see you in June.
Thanks, everybody.
Thank you.
Thank you.